So how many of you have a heart? So then you better pay attention. Okay, how many of you had a friend that had cardiac disease? Okay. How many of you have seen someone that you know pass away because of heart disease? Anybody knows someone that has been to the hospital on a weekend or a midnight because the heart, some chest pain or something like that? All right. I have the chief of neonatology at my institution happens to be the wife of my best friend, and we were having a nice afternoon watching football, which, we like baseball, but we can watch football sometimes. And she calls me that her dad is in the ER because of chest pain. And this is a healthy 65-year-old that is just so strong, he was running and doing everything. 8 hours later, he was dead. And I have to say that I believe that we could have prevented this if we had detected the disease earlier. And how many of you have patients that have passed away from heart disease? I was talking yesterday. One of my favorite patients, one of those guys that have the whole family is very connected to me, to my family, and prostate cancer was destroyed, right? It was PSA was 0, no side effects, no signs of disease, and he passed away from a heart attack. So he beat the cancer, and he couldn't escape the heart. So I am actually ordering the cardiac studies, because sometimes the translation to go to the primary doctor and then having a consult. So I'd rather get the phone call say, hey, you should send the patient somewhere else so that he can get evaluated. So now that I have 2 or 3 cardiologists that are my patients, I just call them, hey, I want you to see this patient. If something happens to him because of the heart, we're gonna have trouble. Anyways, cardiac disease is a big problem. If you think that we have this figured out, think twice. Every second since the Industrial Revolution, when we started having a lot more resources, cardiac disease have become a problem. And you can go and read what Orson Welles, the father of modern medicine, said about this, right? Basically, he's never seen a cardiac disease case in his age, and now you can see it's the most common disease we have. It is not only common, it's the most common leading cause of death. And I'm gonna spend time on this, because if you go home today knowing that this is a serious problem, then you're gonna understand that a serious problem has to be addressed, and you have to look into the problem. That's why we have these new cardiac PET-CTs. Leading cause of hospitalizations, and what is coming first? Heart failure, which is a direct cause of what? Cardiovascular disease. And if you don't understand what happens, this is very expensive. Very expensive, and looks like it's not getting any better. In the near future, it's going to be worse. So we have new things. We have new access, and I think I have one 1 second here. I think we have. It's all right. Okay, I just had a new slide there that is not there, but cardiac PET-CT has a tremendous accuracy. You need accuracy for a tough disease. And it's very efficient. That means you can do it fast, and you can repeat it, and has low radiation exposure. So you have a better test that is safer. And it gives us now information that is directly prognostic. That means that I can tell you what's going to happen. And they have applications beyond just the cardiovascular disease. I don't want to talk too much about the details, but it's accurate, has high resolution, is based on this extraction of these new tracers. And it has the ability of giving you direct information of what is going on with the blood supply to your heart. How does it work? So we are able to challenge you a little bit. How many of you would be breathing the same way that you're breathing right now if I make you run down the stairs 3-4 times? Be a little different, right? So we need to know if there is a problem, and that's why we stress the heart, right? And when you stress, you can do it with pharmacos, or you can do it with running, but these things stress you more. It's a lot more efficient to do it. I mean, you can, if you do the right exercise, something happens, but if doing this, it really opens the door for us to see the problem. And if you look at these images, you can see unique areas in, let's say, when you have stress versus the rest images, you can see what happens. And I will go through right now a map so you can understand what are we talking about. You can see, let's say, you see this map here? It correlates directly with the key arteries that supply blood to your heart. So we can know, let's say here, we can know exactly what area, what artery is causing the problem. Not only that, we can predict what is going to happen in the future if we don't have an intervention. So I can tell you, you see, let's say that you have a perfusion defect here, then you know that in this anterior area, this is going to be supplied by your LAD, and this left anterior segmental artery will cause, this is what, okay, who knows what's the nickname of the LAD? There you go. Because looks like we have not only prostate cancer, but we have a little bit more issues with cardiovascular disease. Men, I'm talking about. So the idea is there is a system that we follow, and now we have access to these. And as you see, I already talked to you here about PET agents, right? You have ammonia, rubidium, and now the question is, how do we get those? So I made it very easy. Oxygen, 122 seconds. That's half-life. You understand what it means? That you just breathe twice and this thing is gone. So you need to have it really, really, really close to the patient, really, really close to the scanner so you can actually do it. Then after that you have, let's say, ammonia, which is 10 minutes. Rubidium, 75 seconds. And now, with the announcement in between the talks was that this, for the first time, we're going to have a cardiac tracer that will be able to go anywhere. And I think that my friends in the back are excited because they're going to have access to this. And this is why, so this is the just nearly approved. I have no conflict of interest with this company, but it's pretty interesting. Now you're going to have access to this cardiac PET in Puerto Rico and in many other places, because now where there is FDG, you could have this tracer, which could change the way that we treat our patients. Okay, let's look at a case together. You guys are experts now. This is our stress and our rest. What area do we have a decrease? What is it? Oh, there you go. I made it easy for you. So you see in this area here, there's decreased uptake, decreased perfusion. It's a perfusion defect, and you can see it right here in the polar map. And which artery is causing this problem? There you go. So this works because we need high myocardial extraction. We need to be able to measure the left ventricular function at the right time. And now that we have information about myocardial blood flow, everything changes. Superior sensitivity. And how do you do this? You do it in a short amount of time with 1/3 the radiation exposure and safe. Let me just go to more details here, but I mean, you can see, with a cardiac PET, you can have access to multiple sets of information. So you can work, it will help you with cardiovascular disease, cardiovascular viability, cardiac sarcoidosis, and then eliminate artifacts. There are some guidelines for this. We're not going to do a cardiac PET in everybody. We have selected the right patients where they have a pre-test probability that is making us worry about cardiovascular disease. And if you can see, if you can see at these numbers here, appropriate, that means that out of 10, when you have cases like this, if a patient is symptomatic with an intermediate pretest probability, who are unable to undergo exercise stress, we do this, right? And if you follow the right protocol, it's not only going to be safe for the patients, it's going to be safe for the insurance companies and the system, right? And you're going to be able to have the right data so that we can prevent more death from one of the top leading cause of death in our country. So let me give you another example. So this is a patient that barely fit in our scanner, and we had one shot at doing this, and we did it right, and we have no issues. The same patient done with the standard and with the SPECT in the past, you could see this patient had a significant concern that we had to send him to do something else. And in this case are interventions that have a lot more consequences, like going to the cath lab and perform procedures that we were not planning on. So let me show you a normal case. Again, you can see the anterior, inferior, septal and lateral walls. In you're able to look at a specific detail on a stress and rest. Let me show you another case. So this case, anybody sees a perfusion defect, and you look at the stress and compare it with the rest images. What was stress again? When you're making that hard work and it's asking for more blood flow, and if that vessel is not healthy, that blood flow doesn't get there. Okay, let's look for a abnormal case. So look, this is another normal case. I don't see any perfusion defect. And you look at all our views. So now, what does this tell you? What is this telling you? If you use cardiac PET, you're able to have the highest diagnostic accuracy. And you're comparing this with an invasive catheterization, which is the gold standard. When you compare, is very correlates. So that means that if you have a PET-CT from a patient that you are really concerned, you actually this could be the gatekeeper between you ordering more invasive tests, which is good for the patient, and it's also good for being a good steward of our resources. On top of that, by having this access to the myocardial blood flow reserve is giving us a significant prognostic value. That means you understand what happens with those patients. And I'm going to repeat this a little bit later, but for every 0.1 unit of decrease, you have a 9% increase in heart ratio. This slide also is telling you that when you compare PET to SPECT, low-risk PET-CTs and high-risk PET-CTs are actually really close to what we find in a catheterization. This diagnostic accuracy is due not only because we're having the right equipment, but also because of having those special tracers that are able to together give us this accuracy. And you see the area under the curve is extremely high. So now let's go head to head and compare. So SPECT have been great for us over decades. Now we have access to bring this here to the island in the next few months. And if you look at the spatial resolution, look at the sensitivity, look at the radiation dose. This is all favoring cardiac PET. And now the game changer is to have the ability of having absolute quantifications.
So myocardial perfusion uses SPECT?
The cardiac PET-CT, now we have access to the myocardial blood flow reserve, which is has the highest prognostic value. We have significant reasons to believe that we're going to have more and more cases where you don't need to go to the cath lab because we can find this earlier. So when you go to the cath lab, it's because you're going to go and do an intervention, which is, how many of you had an invasive procedure in the past? Because I put some of those catheters, and I'm telling you, it's not a day in the park. But look, if you look at the radiation exposure, we're talking about divided by 3 is 1/3 of the dose. This myocardial blood flow reserve capacity that we have now with these cardiac PETs are opening the door for us to be more prognostic and to have better diagnostic skills. And this is basically changing the way we do some things in the future. We're going to be doing things in the future. So this slide is one of the most famous slides for cardiac PET, showing you what happens when this myocardial blood flow reserve changes. And with every 0.1 unit, I said it before, of decrease in the myocardial blood flow reserve, you increase the hazard of death. So prognostic is really helping us answer questions like, does the patient have obstructive cardiovascular disease? No. Does the patient have a need for revascularization? If the MBFR is normal? No. If the patient does the patient has microvascular disease? If this is normal, the answer is no. So technically, with this, we can have a significant change in the way we do things. So on top of what we have there, we can ask, what else can we get of a cardiac PET? And if you do the cardiac PET-CT, you can detect viability. You can get questions into sarcoidosis, management of post-cardiovascular disease, and you can actually look into what happens to prosthetic valves and allograft vasculopathy. So if you look at a perfusion with a cardiac PET versus the metabolism with FDG, you can see if there is viability or not. And let's say in this case, you see you have the cardiac PET with a defect here, and when you compare, let me see, where is the match and mismatch? So FDG, you see this wall here? FDG metabolism is present, here is not. So this area of the heart is alive indeed. Another example of the same. So, any questions? Not yet. Cardiac PET and sarcoid. Having this with the specific protocols will help us improve care for these patients. So it's beyond cardiovascular disease. Now let me show you some pictures about the new things coming. And if you see in the inferior wall here, I mean the inferior septal wall, you see that defect? Very clear, right? It's not in the rest images, and you can see it in the stress images. Let's see if we have a defect here, right there. You can see it in the anterior wall and in the stress images, stress on top, rest on the bottom. Another case, let me see, anybody sees a defect here? You go through all your walls, stress and rest. I don't see anything here. True. Do we see one here? All right. These beautiful images are changing the way we treat these cases, and that means that we have better outcomes. Okay, do we see a defect in a perfusion defect between the stress and the rest images? Not there. What about here? Anybody sees a defect there? All right. So we have the opportunity of having access to cutting-edge technology that is going to help us do exams faster and more accurate. All right, anybody see the defect from the back? There you go, anterior wall. What about here? All right. All right, so what about here? You see something in the inferior lateral wall? All right. So let's move beyond these pretty pictures and look at calcium scoring. Anybody knows about calcium scoring? So this is a byproduct of doing a CT scan to look at the coronary arteries and how there's calcification or not. And then we have a score that tells you that if you're a 0, basically a negative test, this is telling us that the findings are consistent with low risk of having a cardiovascular event in the next 5 years. I believe this low-cost exam could help us prevent the visits to the ER in the middle of the night. And let me show you a couple of cases. You can, what artery is involved here? There you go, that's right. Left circumflex. And here we have, which artery is this one? That's a bypass, that's right, it's a big one. But then you also have the LED. And also here the circumflex. And so if you follow these beautiful pictures, you can see the extent of calcifications where it will correlate with a problem that you could have in the future. That means that you have a score like this, you're going to be in the radar of your cardiologist, and that means that you can have chances. So this is a 43-year-old versus a 63-year-old, and you can see the difference. This is a completely normal scan, and patient will do great. You will not have to deal with a lot of the artifacts that we had in the past. Today, with this new technology, we will be able to more accurately diagnose, and by having access to the myocardial blood flow reserve, we can predict outcomes. And that is priceless in this arena, especially in a field where there are high stakes, where we can have a say on how to fight heart disease by having better tools to diagnose and treat. All right, thank you so much.
Visualizing scan.